Hi everyone, my name is Ashley Bowlin and I'm a registered nurse with my Master's of Science in Nursing Education, and I'm here to talk to you today about metabolic acidosis versus metabolic alkalosis. So I'm going to move down into that little corner in 3, 2, 1. Hi! So I'll stay down here during the duration of the presentation, and at the end I'm going to pop up and we're going to have a fun game. So let's get started. So the first thing I want to talk today is about the learning objectives. And by the end of this unit, I want the learner to be able to differentiate between pathological responses of metabolic acidosis and metabolic alkalosis, discuss causes for both metabolic acidosis and metabolic alkalosis, list symptoms of metabolic acidosis versus metabolic alkalosis, identify anticipated treatments as well as nursing interventions for both metabolic acidosis and metabolic alkalosis, and determine if a patient is in either metabolic acidosis or metabolic alkalosis based on presenting arterial blood gases. So the first one we're going to discuss is metabolic acidosis, and this is a condition in which the body is accumulating too much acid, and it can be either by too much production of acid, which is a problem with metabolism, not enough acid secretion, which is a problem with the kidneys, these little sad sick kidneys here, or a loss of bicarbonate, HCO3. There's a dumping of bicarb somewhere. So the body's experiencing high levels of acid, so the lungs in any metabolic issue comes in and tries to help. And it tries to compensate with hyperventilation, Kussmaul breathing, which is a deep, rapid breathing pattern. And the reason behind this is that the lungs have CO2 in them, and CO2 is acidic. So as they take these deep breaths and blow them out, it's blowing the acid off to help bring the acid levels down. Normal ABG levels, these are super important to know to commit to memory. pH normal is 7.35 to 7.45. Now, pH is a measurement of hydrogen ions, which is represented by H+, and it's the concentration of hydrogen ions which are acidic. And so the more hydrogen ions you have, the more acidic you are. Bicarb normal is 22 to 26, and it's a byproduct of metabolism. And PaCO2, 35 to 45 normal, and it's a byproduct of ventilation. So in acidosis, pH is going to be less than 7.35 because we know on the pH balance, higher level numbers are base, lower are acid. So if we're moving towards the acidosis, we're going lower. Same with bicarb. Going lower, we're heading towards acidosis. PaCO2 will go lower if it's compensating, or it can be normal if the lungs haven't decided to kick in and help yet. Now, PaCO2 is reversed. So lower numbers are indicative of that the body is trying to blow off some of this acid, so it's trying to move to base more, so more of an alkaline situation. So there's two types of acidosis, high anion gap and normal anion gap. Well, first off, what's an anion gap? And it's just the total difference between plasma cations, which are positive, and plasma anions, which are negative, and it's represented by sodium minus chloride plus bicarb. And the normal range of an anion gap should be 10 to 14 milliequivalents per liter. But if there is a greater than 14 milliequivalents per liter range, then it's a high anion gap. In those situations in which we talked about, the body is producing too much acid and not enough bicarb. And then you have the normal anion gap, and those is where the body is losing too much bicarb. There's a dumping somewhere. So what are some causes of metabolic acidosis? And I love acronyms. Acronyms help me study in nursing school. They help me prepare for the NCLEX, and I still use them today in my practice of nursing. So today, the cause is acidotic. So the first A, aspirin or salicylate toxicity. It's a high anion. So if someone consumes too much aspirin or salicylate, it breaks down into salicylic acid. So just too much acid in the body. Same way with alcohol toxicity. High anion, someone consumes too much alcohol, it is broken down into acetate, which is another acid, so too much acid. Lactic acidosis, high anion. Now, you may have heard that the body produces lactic acid, the tissues produce lactic acid as they are not getting perfused like in exercise. But lactic acidosis doesn't happen unless there's an extreme loss of perfusion and oxygen to the tissues. So in either extreme exercise or other causes like shock. Insufficiency of kidneys, high anion. So kidney failure. The kidneys just can't keep up. They can't excrete all the acid, and it builds up and builds up. And like potassium, which is a hydrogen ion, it builds up and it's acidic. Diarrhea. Now this is our first normal anion, and we discussed that if you have this dumping of somewhere, you're losing all your good alkali and you're building up acid. Well, in the intestines, you have alkaline contents, and therefore if you're losing it through diarrhea, you're going to be acidotic. Diabetic ketoacidosis, DKA, another high anion. So in diabetes, we know the issue is insulin. You've got all this sugar floating around, and the cells need the insulin to move the sugar into the cells to be able to use it for energy. Well, in diabetic ketoacidosis, you just don't have enough insulin, like with diabetes, of course, diabetic. And then the body begins to eat at the fat, and that breaks down into ketones, which is acidic. So these patients are diabetic, so diabetic keto for the ketones, acidosis. Shock. So whether it be by someone is anemic or hemorrhaging or they're septic, the tissues are not getting perfused, they're not getting oxygen, and therefore the body will build up that lactic acid, and they're high anion lactic acidosis. Fistula, normal anion, so there's this passageway between two organs that's not supposed to be there, and this can be in the small bowel, and so that alkaline contents is dumping out, so we become acidotic. Increased fat intake or starvation, high anion. So either this is by diet, so like the keto diet, where nobody, when they're on that, nobody is going to eat carbs. And so what happens is the body begins to eat off of fat and break that down. Well, starvation's kind of the same way. It doesn't have carbs and sugars, so the body eats on the fat, breaks down into ketones. Ketones are acidic. Carbonic anhydrase inhibitors, Diamox. It's a high anion. What happens is Diamox is a bicarb reuptake inhibitor. So it tells the body, hey, we don't need this bicarb, let's get rid of it. So it gets rid of the bicarb, and then you end up being in acidosis. So what are some symptoms? Headache, decreased blood pressure, changes in level of consciousness, but the main ones, hyperkalemia. Remember, the kidneys cannot excrete the hydrogen ions, that being a potassium, and it builds up and builds up. So we have too much potassium, and potassium is a huge helper with muscles, so you end up having muscle twitching, and you get warm, flushed skin, and most of all, we have those Kussmaul respirations, those compensatory breathing pattern where the body is trying to blow off too much acid. So here's a patient that's in diabetic ketoacidosis, and this is Kussmaul respirations. Notice the deep inhalation, the deep exhalation. These patients can breathe up to 40 times or more a minute. And so you see that if this continues on and on, that this patient can be in respiratory depression. So then we want to talk about the different types of treatment and nursing interventions for metabolic acidosis. So acidotic, again. So aspirin or salicylate toxicity. You're going to anticipate activated charcoal for those toxin reabsorption. For alcohol toxicity, a lot of times these patients are just getting symptom relief until the body is rid of toxins. Lactic acidosis. Now we talked about the problem is oxygen, lack of oxygen and perfusion. So how about some oxygen and some IV hydration for tissue perfusion. Insufficiency of kidneys. Now, if the diuretics don't work, patients may have to have dialysis. But as a nurse, we want to do strict intake and output because these patients can get overloaded very, very quickly. With diarrhea, anti-motility drugs, so let's stop the diarrhea and let's rehydrate them, okay? With DKA, the problem is insulin, so guess what? We're going to give them insulin per our MD orders. But it's important to monitor those blood sugars because just as quickly as they are hyperglycemic, they become hypoglycemic. So look out for those signs of hypoglycemia, okay? Shaking, diaphoretic. Shock. Let's treat the cause of shock, okay? So if they're anemic, they may need iron transfusions. Heart failure, they may need a heart pump or a transplant. Hemorrhage, they may need infusions. A fistula, surgery, is going to have to repair that. Increased fat intake or starvation, they're going to need a dietary consult for a balanced diet. But if starvation's based on anorexia, they may need a psych consult. And if you're given Diamox, then we're going to have to stop it. And these people may need sodium bicarb in extreme cases. So now let's flip to the metabolic alkalosis. Now this is the opposite. This is a condition in which the body is just having too much serum bicarbonate, HCO3. So there's either an overaccumulation of bicarb or an excessive loss of acids. Remember those hydrogen ions, we're losing them. So the body again tries to compensate. These sweet little lungs try to come in and help their kidney friends, but this time they're going to hypoventilate because they're going to hold on to that CO2 in the lungs to try to build up the acid levels. These people can breathe less than 12 a minute, so we want to be very careful. Just like I talked about with the Kussmaul respirations, we've got to watch these people for respiratory depression. Normal ABG levels, I'm going to include them again because they're super important. Alkalosis ABG levels. So the pH is going to go up because remember, moving towards the base, alkaline. Bicarb, we're going to go up again because we're moving towards the base. But PaCO2 will go up only because we're trying to hold on to the acid, and CO2 is acidic, and this is a byproduct of ventilation. So if it goes up, then we're trying to help out. The lungs are trying to help their buddies out. But it can be normal if the lungs aren't doing anything yet. So what are some causes of metabolic alkalosis? Again, I love my acronyms. So alkali. You've got aldosterone production excessive, so hyperaldosteronism. And what happens is the body's producing way too much aldosterone. The aldosterone tells the kidneys, hey, hold on to sodium, get rid of the potassium. Well, potassium is hydrogen ions, which are acidic, and so we can go into alkalosis. Loop diuretic is kind of the same thing. These are non-potassium sparing diuretics, and it tells the kidneys, hey, we don't need the potassium, let's get rid of it, and the chloride. Losing hydrogen ions, we can go into alkalosis. Alkali ingestion. So someone either taking baking soda too much for acid indigestion, or eating a bottle of antacids, drinking too much milk, and having like kidney issues, and you can't filtrate it out, then all this broken down is into bicarb. Too much bicarb. Anticoagulant. So citrate is used in blood transfusions as a preservative. And if someone gets multiple infusions, like 8 or more, as this is broken down, citrate's broken down into bicarb, too much bicarb in the body. Loss of fluids, so severe vomiting or NG suctioning. So in the stomach, the contents are acidic. So if we're losing the acids in the stomach through NG suction or vomiting, we become alkalosis. And an increase in sodium bicarb. So guess what? We tried to treat them for acidosis, and we threw them into alkalosis. All right, so what are some symptoms? Some kind of the same with acidosis, like restlessness, confusion, nausea, vomiting, diarrhea. But the big ones, hypokalemia. Remember, we got rid of all of our hydrogen ions. We got rid of our potassium. So now we have a low level of potassium, and that can lead to tremors and muscle cramps. And most of all, most dangerous, is that tachycardia, dysrhythmia, and those hypoventilations. So what are some treatments that we would anticipate in nursing interventions for metabolic alkalosis? So the aldosterone production excessive system, we're going to anticipate giving aldactone. That tells the body, hey, I don't need all this aldosterone. I'm going to get rid of all this sodium I held on to, and I'm going to keep some potassium, and helps correct the system. Loop diuretics, we're going to anticipate stopping them and watching those potassium and chloride levels, and possibly they may need some supplementary potassium and chloride. Alkaline ingestion, educate on the dietary limit of it. As far as the citrate, we might have to stop those. We're going to have to stop those multiple transfusions and might have to give a volume expander. And for loss of fluid, severe vomiting or NG suction, stop the NG suctioning. It's important. Stop that, and let's give some antiemetics and IV hydration if the issue is with the vomiting. And in increased sodium bicarb, we're going to have to stop the sodium bicarb administration if that's what's causing the alkalosis. But most important, for all patients, acidosis or alkalosis, you want to make sure to monitor those vital signs because blood pressure can change. Levels of consciousness, we've seen with both of them that they can have lethargy, decreased levels of consciousness. Monitor those arterial blood gases. They can change quickly. We can get better or we can get worse. Signs of respiratory depression. We either breathe too fast or too long, our lungs are going to tire out, or we just breathe too slow for too long. We're going to end up getting respiratory depression. And place them on seizure precautions because everybody that's in acidosis or alkalosis, they are at risk for seizures. So now, got my references and it's game time! Yay! Okay, so I'm going to pop back up here. Hey! All right, so the game I have today is tic-tac-tosis. Okay. So tic-tac-tosis is a fun game that will help us to be able to determine, based on respiratory gases, arterial blood gases, if someone is in metabolic acidosis or metabolic alkalosis. Okay? So the first one I've got acid, normal, and base. And I've got my little tic-tac-toe right here. And I went ahead and put my pH and my bicarb and my PaCO2. But as good nurses, we're going to know these by memory, right? Right. Okay, so your patient comes in. You get a pH of 7.23. So we know that that's low. So that's going to go in our acid. So I'm going to put it right here under acid. And my bicarb is 11. So that's low. So my bicarb is going to go under acid. And my PaCO2 is 42. Well, that's normal. Okay. So pH stands for acidosis. And bicarb is always a byproduct of metabolism, so metabolic. So we're in metabolic, tic-tac-toe, 3 in a row, metabolic acidosis. Now my PaCO2 is not changed, so I'm non-compensating. But guess what? A couple hours I check, and my PaCO2 has changed to 33. So now it's moving down, so I'm going to go over here towards my base. So I'm partially compensating now. In a couple hours, if I check and my pH is normal, then I'm fully compensating. Okay? All right. I've got another one. Erase this. Okay. Okay. So your patient comes in and they have a pH of 7.5. So 7.5, let me fix this. 7.5 is high, so it's going to go over here in the base. So pH, okay? Their bicarb is 30, okay? So we got 22 to 26, and if it's high, it's moving towards the base. So it's going to go over here, HCO3. Now, let's not finish it just yet. I know we've got a tic-tac-toe 3 in a row, but let's keep going, okay? Our PaCO2 is 40. So 35 to 45, 40. So it's going to go into the normal range. Okay. So we know we've got a tic-tac-toe 3 in a row. pH, and it's under base, so it's going to be for alkalosis. Okay. And then bicarb is for metabolic. Okay. And then our PaCO2 is standing for respiratory. So now we are in metabolic alkalosis. Now our PaCO2 is normal, right? So it's non-compensating at this point. But remember, we said that can change. The lungs say, oh, I need to help out. I'm going to come in and I'm going to help, and I'm going to alkalosis. I'm going to hypoventilate, so I'm going to hold on to some of those acids. So now you go back and you notice the patient's breathing really slow. We're hypoventilating. So I've checked my my PaCO2, and now it's 50. So guess what? It's going to go into the acid area. Okay, so we are in metabolic alkalosis, partially compensated. But if we check in a couple of hours again and that pH has gone normal, then we are fully compensated. So for the students, I'd have a sheet of several of these problems to do, to work on, and to have completed by the time they come back for their next class. Thank you again for taking the time to watch my presentation on metabolic acidosis versus metabolic alkalosis. I hope you have a blessed day, and I'm excited to interview with all of you. Thank you. Bye-bye.